It's a real pleasure to introduce Dr. Anurag Bsbe, today's speaker. This is the 5th edition of Tech Talk with a Doc that is happening today. Welcome, Dr. Bsbe, to IIT Kanpur and all your colleagues. Thank you all for coming here. So, Dr. Bsbe is a doctor thoroughly trained at All India Institute of Medical Sciences, both at MBBS and MD level. And then he spent time in Royal Children's Hospital in Australia. He is, apart from being a practicing physician, he is a prolific author, a researcher. So I knew about his research orientation because of association with him through my daughter, of whom he is the physician. So he is the section editor of endocrinology in Indian Journal of Pediatrics, reviewer for pediatrics, Indian Pediatrics, Journal of Pediatrics, and Journal of Pediatric Endocrinology and Metabolism. He has authored more than 50 research papers and book chapters and books. He has been prolific and he is a fantastic doctor, and we are very, very happy to have you here today. Little bit about this talk series for you and my colleagues who are perhaps here for the first time, and for the students who are here for the first time. So, as we were discussing today, we also have a representative from Invest India in amongst us, Mr. Himanshu Malik, seated there. So, we have been identified by Government of India as one of the nodal centers to promote innovation and incubation throughout the country. As we often discuss, that inside this 16 square kilometer campus, there is a lot of skill to solve problems, but we are not very sure often which problem to solve. So, Tech Talk with a Doc is our effort to bring the problems within the campus which can be solved. So, now after 4 editions, from the 5th edition onward, what will happen is that the talk will be immediately followed by a hackathon, meaning the problem statements that the doctor will offer, you will be given a chance to take a shot at it, to solve it. The details will be provided by Aditi. The problem sets have already been kindly provided by Dr. Bsbe. So, we will give you a QR code, you can scan it and you will get the problem statements. And within the weekend, you should provide your solution to us. Reviewer's decision is final. The winners will be given 2000 rupee cash prize, and if you so desire to not to take the cash prize, instead to actually develop the product, we will, if the solution is feasible, we will support the entire development process, okay, as the incubator of IIT Kanpur. So, with that and the fruit hanging in front of you of the hackathon and the cash prize and the recognition and everything, I would like to invite Dr. Bsbe. Thank you, sir. Thank you so much.
Thank you, Dr. Amitabh, and it's really a very interesting concept that we are really seeing today, and it's really the interface which we have been looking at, because as physicians, we often tended to be towards the end spectrum in terms of end users of various technologies, and we are not in a way involved in shaping the technology. The problem really lies in that there is a disconnect between people who are developing the technologies and how they are used. So therefore, we have things which are not really helpful to us, but we are forced to use it because we don't have much options on that. But I think this is a very nice platform to discuss and see what our problems are and how we can solve those problems. So the problem today we're going to talk about is type 1 diabetes. So how many of you have heard about type 1 diabetes? So yeah, so I think a lot of you have heard about it. So I would just show a brief issues about what plagues the problems in terms of children who have diabetes and how this could affect. So this is way just showing how this problem could be there and how it affects. So as this small infographic showed you, that type 1 diabetes is one of the most challenging conditions anybody can face. So you need to take insulin 4 times a day. If you skip one insulin, you may land up into high sugar, then that may cause problems. If you don't eat well, the sugars may go high or may go low. If you become sick, you can really become sick and require hospitalization. So this is one condition. And in fact, one of my professors in Australia used to say that if you compare, some people will ask you which is worse, having a cancer or having a diabetes. So theoretically, we know that cancer has a lot of issues in terms of outcome and everything. But he said the amount of intensity and the commitment that a family with diabetes has to give is something which is really more. And that's why we need to do something to help out on that. So just to touch base on what really type 1 diabetes is, it's basically an immune disorder in which in a genetically predisposed individual there is some environmental trigger, and that causes damage to the beta cells which produce the insulin, and as beta cell function decreases over time, we require insulin, and I would say most of our children require insulin injections 4 times a day. So if you talk about somebody who is diagnosed at 3 years or 4 years of age, we are talking about 70-80 years of having 4 injections daily. So that obviously is something which is difficult to fathom. They would require 4 to 6 times sugar monitoring also, and they have to adjust the doses. So this is a really challenging condition. Just to give an overall idea as to how common the condition is, it is around 1 in 300 individuals, and so there will be over 2 lakh children in India, and unfortunately many of them are not picked up. So that is the first problem, obviously, that people are not even being picked up and they are missed and they would die because they are not being diagnosed with diabetes. I will just showcase this small video which was actually made by one of the school children from KDMA as part of the IIT Kanpur and Grow India. Grow India is an organization. We run a movie making workshop for schools, and then we give them a problem. So we gave them a problem of type 1 diabetes, and they made a very nice movie summarizing all of this in a brilliant fashion. So this really highlights how type 1 diabetes could be a life and death matter for everybody who is, and this is, we're talking about somebody who can afford insulin. Of course, somebody who cannot afford insulin, who cannot get glucometers, will have a huge challenge. We're talking about somebody who can do everything, still there are issues. So what I've tried to do is put the challenges of type 1 diabetes into 3 categories, and this is true for all diseases. When we talk about any diseases, there are 3 aspects which are important: awareness, accessibility, and affordability. And these are the 3 issues which needs to be tackled. And I would say, if I ask you, which of these 3 is the most important for any disease? Let's forget about diabetes. We talk about any disease, which is the most important we should focus on? Awareness. Because if people are aware what symptoms of type 1 diabetes are, they will be picked up at the right time. Our experience is that every year 50,000 children probably are diagnosed or have diabetes in India, but they are not picked up, at least half of them, and they would die because of complications. So if we increase awareness, that becomes easy. Children who come to us in Kanpur come around 50-60% come in ketoacidosis when they are really sick. So they are children who need to be picked up early. So I think awareness is a big issue. Then after awareness, of course, accessibility. So we need to have things which are available first. Then comes affordability, because affordability is the last issue. If things are not there, if solutions are not there, we'll talk about a lot of these solutions which are quite expensive at the moment, but how we can make it affordable comes last. So we have been focusing largely on the awareness part, and now probably we'll talk more about how we can make things which are accessible and helpful for these children, and then finally how that can become affordable. So we have been working with the design department for the last 5 years or so. Dr. Satyaki and his team have been involved with us, and we have been conducting multiple movie making workshops and design workshops. And in that we have till now, I think 500 students from different parts of Kanpur have been in a way exposed to type 1 diabetes and other health issues, and they have been asked to make movies like this which you saw, and they have really helped a lot in terms of increasing awareness in the lay public. We also have our website where all the videos are available, so this is working in terms of awareness. And we have set up clinics especially for children which help them providing discounted and free insulin and other meters. We are training the schools, so all these parts are going on. And recently the other issue is that because physicians themselves are not very well trained, so a lot of pediatricians are not really aware about type 1 diabetes management. So we recently started an online course for pediatric endocrinology overall with a large section on diabetes. So these are the things we are working in terms of making the general public, the schools, the doctors aware, so that we pick them up on the right time. Now what happens next once those children come to us? How can we make their lives better? So what are the main challenges that we are dealing with? Challenges are mainly in terms of the issues of day-to-day care. So they have to do so many, so imagine how many of you would be really comfortable taking so many injections, measuring so many sugars, having diet control, count each carbohydrate you're taking, then adjust to that. That is a big challenge. Second, invasive monitoring. Every time a family comes, they say, आप कहते हैं 4 से 6 बार करें, whether we can do it 2 times, 1 time, or once a week, something like that. That obviously is going to have a very bad outcome. So how can we improve the invasive monitoring part? Injections. And I think this is the main bone of contention. Every time a child will come, they will always ask, how long do we have to take the insulin? Whether there is some other way which we can use and which will be of help. And finally, everybody wants a cure. So although we always say the child is fine and everything is fine, but everybody is focused on cure. So how we can remove the disease? So these are the 4 key issues in which we can think of possible technological interventions which can help us improve the lives of these children. So now I'll give you an example. A 5-year-old girl with diabetes takes 4 injections a day, 6 times glucose monitoring. She has to count the carbohydrate, the family members will do that, and then they have to use a lot of calculations to get that. So you need to have a lot of real inputs for somebody who knows about all those things to do, but most of the children who come to us and the families are not able to do it on an easy basis. So 80% of them, obviously, because when we say you have to take insulin, 80% will take 4 times a day, some of them will skip. Glucose monitoring 6 times a day, I think Neha will tell us, because our studies show that I think it should be less than 10%. Carbohydrate counting less than 5%, because we also feel it is difficult to spend so much time and they are not able to understand that, and how do we use that. And again, these calculations vary. So that makes things very difficult, and if we have that problem, of course the complication rate will go up. So we are not only talking about their mortality, that is the first issue we talked about, we are talking about morbidity. We are talking about children who are having renal failure at around 20 years of age, their kidneys are going bad, eyes are going bad, all the organs are getting damaged just because they are not measuring enough glucose, they are not doing the proper calculations. So now I think this is the first point, what could be the possible interventions? So anybody can think of it. Or you want to keep it at the end?
Like, like not interactive, but
Yeah.
we will write down the problems and we will give them.
Okay, yeah. So the possible interventions in this we have been working for quite some time is in form of various mobile applications to make it easier. And now most people have mobiles so that they can do all the calculations, they just feed, and there are now applications which actually if you take a picture of the food, it will tell you how much carbohydrate is there. So things are becoming easier, but many of them are not really targeted to Indian meals. And they will talk about pasta and pizza when they will be asking something else in time. So it is not, the local relevance is less there. So if we have a simplified app, probably in local languages, which can really help out in terms of that. So if we give the child this, okay, you take a picture, now you know this is what you're eating, you take your sugar levels, and then we have calculations which we can feed in as to how much insulin will cover, how much carbohydrate, how much insulin is required to cover glucose, and that could really help out in terms of making a decision. So I think this is something which is going up, this is improved. So this area, 5 years ago I had met Dr. Satiki, there were hardly any, but now it is improving, but still a lot of work to be done in this regard. 10-year-old boy with type 1 diabetes lives in a remote village, and this is a very common problem. A lot of them don't come. When we say you come after 5 days or 7 days, they find it very difficult. So poor communication, confused about treatment. So what are the options available here? So we talked about one, having too much information and how to process them. So that was the application. But how do we connect to somebody who is staying out? How do they communicate? How do we have a two-way communication? Because if we tell them that, okay, you send your sugar readings, you call us, it becomes very difficult for our team to get so many calls. So what could be the possible solution for a situation like this? So one possible solution, of course, is that if we have a connected device through which they directly upload the readings which come to us directly. So it's a seamless communication. They take the sugars, they come to us, and then maybe our team speaks at a time which is relevant from our side. We can do it easily and from their side. So this is something which we have thought. So this is something which is already some people are doing it. Diabetacare is one company which has started this, but we need to think of in a mass scale as to how we can do it in an affordable manner, because their glucometers are charging a lot, and then there are a lot of issues about internet connectivity. So if suppose somebody is, let's say, sitting in some village in remote part, they check a sugar, it directly comes to us, and some of our team can from backhand communicate with them. This is something which we are looking at, and this could be an important solution which can happen. So we talked about the ambulatory care, and these are the relatively easier, I would say, because probably these are more of a software implementation, but now we're talking about more substantial changes which can be there. So invasive monitoring. So 2-year-old boy with type 1 diabetes requires frequent monitoring, really cries a lot, that's why his sugars are all sometimes it's low, it's high, and severe hypoglycemia. So what are the options which are available? So what we are basically looking at here is that instead of doing a finger prick, can there be some other way in which we can measure the blood glucose in a reliable manner? So any non-invasive measure which will be of help on that. What we have at the moment available are continuous monitoring systems, which basically you have to put a patch which can be put in the arm or the stomach or something, which give you sugar of around 7 days, 14 days. So there are various systems which are available, which can be used. They are quite expensive. So if you talk about the Dexcom, this would be, I think, couple of lakhs, and then for every week they charge a lot because they have to change the sensor. This is the cheapest one, which basically will cost around 5,000 rupees for a 14-day reading. So this is a reasonably okay one. It gives 15 minutes monitoring for a 14-day period. But again, the cost is there, then the reproducibility and other factors are important. So this is one way of looking at it.
So this is invasive?
Yeah, so this is not really non-invasive, so you have to put it up. So it's like a small, so you could maybe, rather than having so many pricks, you put it once, and then it measures the interstitial glucose every 15 minutes for 14 days, this one. So once you have to do that. So these are invasive, and then you have sensors which will put on that. So they are good technologies, mainly used in terms of rare cases where we have problems. Like if we are not able to adjust, we do this. But routinely doing this, the cost is very expensive and prohibitive, which we don't do in most setups. Now this is, but still, as Dr. Chandra has pointed out, that this is still invasive. You have to still put something in. So can there be something non-invasive? I think, I'm sure this is going to be a big challenge to go forward and find a non-invasive way. And it is possible. I would say it's not impossible, because we have seen in clinical practice how various non-invasive measures have come into picture. So this is what is the blood gas assessment. So in this you check the blood and see how much is the oxygen concentration in the blood. So we do it for sick children. But imagine every time you puncture an artery to get that, it is going to be extremely difficult and going to be not possible. So what was designed, and you would have seen, anybody who is in the ICU now has a pulse oximeter. And now this is available even in the clinics. People have a, so something which was so complicated, you need to have this arterial puncture, you have to take the blood, you have to take to the specific lab, and then they will tell you, now you can readily use a finger, you put your thumb in there and you get the result in terms of saturation. Or you have a watch. Now I think Apple is also coming up with some ways, already heart rate is there, they are talking about saturation and all. So can we have something which is as easy? Now we have wearables and so many things, whether this will be something which is going to be a huge help, because then you don't have to put any blood. You can actually have a continuous monitoring every 15 minutes or something, and then that could be really, really helpful. There are some things which have been there, which are in work in progress, but none of them is actually commercially available. There have been work on non-invasive measures for the last 20 years. But all of them, the problem is that they don't correlate very well with the lab results. See, as a physician, I would like that when you say the sugar is 60, it is 60. But if this 60 is 100 or 20, then obviously it doesn't make any sense for me. So we need to have, first of all, we won't compromise, we will better be doing a prick rather than compromise on the level reading. So that's the primary problem there. So there are some devices which basically use the infrared technology. So they send the infrared and they see how much glucose, how much the temperature changes in terms of glucose levels, and then they try to assess it that way. They have some other technology, this is a German technique which is also coming up, but these are all work in progress. So if a non-invasive glucose monitoring comes up, this is going to be a huge success, not only in terms of commercial success, but also in terms of will help the lives of crores of people, not only type 1, type 2, everybody. And this could be very helpful for small children who are newborns, who are in the NICU, where you just measure the blood sugar. So it becomes very, very effective thing. And now I would say that with so many developments happening, we are having cars which can be running without humans. We are talking about so many other things happening. I'm sure this is not going to be a very difficult thing with so many technology that we are wearing anyways. So if we can develop something like this, this will be a boon for children with diabetes. And I think it's a very challenging problem, but one which should be taken up definitely in some form. Yeah.
Because I am ignorant.
Yeah.
Is there any correlation? One can measure intracellular glucose.
There is a good correlation between blood glucose and the intracellular glucose. However, the correlation is best with the interstitial fluid glucose. So the cells, in between the cells, the interstitial fluid is there. That correlation is best, because the intracellular glucose will also depend upon how much insulin you have, because insulin will push that glucose into the cells. So in a normal individual, there may be a good correlation, but if somebody is diabetic and their insulin is less, we don't know. So most of these technologies are talking about interstitial fluid. So they're trying to extract glucose by iontophoresis, or something like glucose comes out, or they are putting in rays. So this is the way it is. But I would say there will be a problem in intracellular correlation, because then there will be issues on that.
Okay. Because I was thinking that, why can't you measure from exfoliated cells?
Okay, yeah.
Relatively non.
Yes. So I think this is a good area to work on, and overall a lot of work is there, but nothing has come out in terms of commercial use. The second issue obviously is in terms of injections, and this is a major issue as to giving 4 injections a day, and we used to give big syringes were there, now syringes became small, needles became small, now the pens are there, pumps are there, but still
you have some amount of invasion which is there. So 14-year-old girl diagnosed at 3 years of age, good control for 3 months, till 3 months ago, but now she's missing doses because she doesn't like that injection all the time. Sugars are high, and that's a big problem. So insulin definitely is one of the most wonderful discoveries in biological sciences over the last century, I would say, because it has saved hundreds of thousands of children. And this is the picture of Banting and Bsbe, who actually discovered insulin. And this was a pancreatized dog, and the dog was having ketoacidosis, was lying down, and they gave insulin, and the dog got up. And there is a very interesting story which is there, that there was a ward in which there were, I think, 100 children of diabetes who were lying, and all of them were in unconscious state. These two gentlemen started giving injections of insulin, and by the time they reached the last one, the first child woke up. So this was like a dramatic improvement, and within a few years they got the Nobel Prize. So this was, Bsbe didn't get, which is a lot of controversies there, but definitely this was one of the most life-changing decisions or interventions which happened. And you can see that how things change, and we see children coming like this, which is a sad thing because of awareness and all, and then they can become absolutely normal if they get insulin. So it was universally fatal, dramatic improvement, but still issues are there. So these are the various injection devices. We have the syringes which are there, pen is there. Now we have these sort of devices which you can put for few days, so you don't have to inject every time you inject the device. So that becomes less painful. For children who actually have needle phobia, they are jet injectors, but ultimately you have to inject insulin. That's the key principle. The other options now as to how we can use non-injectable insulin, this becomes a major issue, and this is again going to be of help. So these are the various routes through which insulin can be given. We can give it through nose, oral insulin, inhaled insulin, transdermal insulin. There's a lot of work about insulin patch. You put a patch which basically provides the insulin, and some people have actually developed beta cell patch. So you have the beta cell, actually live beta cells which are put as a patch, and then they provide insulin directly. Why helpful? Because beta cells can sense your glucose. So they will know how much glucose you have, and they will give that insulin. But of course that's not been practical at the moment. Inhaled insulin was the first one tried, and we know as inhaled steroids, a lot of people would have seen for asthma they were using inhaled. Same was for insulin, but then these were not very effective. So the only inhaled insulin which is now approved across globe is Afrezza for adults as a bolus insulin. So meal time you can just take a puff. But we don't recommend for children, of course, because we don't know. Somebody has a blocked nose, somebody has asthma, how much insulin is going to come to the body. So this is something which is quite attractive, but unless we have an effective way of delivering, again, we would not compromise just because you're giving a puff instead of an injection. The child lands up into decay and he comes to the ICU for a few days. So we want something which is quite robust in terms of delivery. So this is an interesting way. So whether some non-invasive method can be delivered, whether it is a beta cell based, insulin based, I think Dr. Amitabh has a suggestion.
No, we have a suggestion just to let you and the audience know. Exubera
Yeah.
has an IIT company connection.
Okay.
It was developed by a company whose main mover is Ajit Gill, our alumnus.
Okay.
It was outsourced to Pfizer.
Pfizer, yeah.
And there were complications.
Yeah, so there were issues about respiratory, malignancy, a lot of other things. So in biological sciences, of course, when you do researches, it's going to take a long
Lag time, and there are a lot of issues about you have to safety and all the other issues will be there. So Exubera was an interesting product, but unfortunately had to be taken out of the market. So now Afrezza is there, but again not, maybe less than 1% of all people will be using that insulin. So of course insulin pumps, that is a way to go forward, but this was the first insulin pump developed, and you can see if you have this much amount of pump in your body, probably you will have enough exercise and you don't need the pump at all. All your energy will be lost carrying that pump. Since then, a lot of improvements have happened, and now we have very good pumps which actually have a real-time sensors also. So you can actually have sense the blood glucose, you put the sensors, they communicate with that. There are pumps which actually are able to tell you now you decrease the insulin, now you shut down the insulin. But still they are not the complete closed loop, as we say. So some people talk about artificial pancreas, in which the whole pancreas is being created artificially. That has not been done, but still and the only other issue is that Medtronic is the only company which is actually working on insulin pumps. There were other companies which have gone back. So there is a monopoly sort of a segment which is there, so that's why the cross is huge and that becomes an issue. So these are the Medtronics, what they call as a closed loop system or artificial pancreas system, in which you have a sensor which tells you how much the blood sugar is, and then this insulin pump through the algorithm gives a delivery. The problem here is that you have to still prick after every 3 days, you have to put up the injector, you have to put the sensor continuously, which has to be changed, and then these algorithms, we don't know whether they will work in all situations, in all perspective, so still you have to monitor very closely, but we are much better off. This is a very interesting device. This is known as bionic pancreas or islet. So this is going a way forward. So I'll just maybe ask somebody, some of the students, as to what are the other things which are secreted by pancreas other than insulin, other hormones secreted by insulin, by pancreas? Glucagon and somatostatin. Okay. So glucagon is very important for maintenance of glucose. So you want to maintain your glucose up, you have glucagon. The other, somatostatin inhibits the alpha and beta, so it inhibits both insulin and glucose production. So what this device does, this is a dual chamber pump. So what it means is that it has insulin on one chamber and glucagon on the other. So if your sugar is going down, it will not only decrease insulin, but also give glucagon. So in a way it balances both way out. So this is a finer version of it, but again only experimental, quite expensive. This is known as islet or bionic pancreas. So hopefully this is the way forward we are looking at in terms of long term. The problems here is that we need exact accurate delivery. So when we say 0.1 unit per hour, it has to be 0.1 unit per hour. It cannot be 0.06 or 1.4 because that will cause hypoglycemia or hyperglycemia. So it has to be very, very precise in terms of delivery. If there is a resistance, we should know that there should be an alarm in the pump. So a lot of issues are there, and initial pumps caused more problems than solutions. So people used to have more ketoacidosis because suppose the pump is not working, you have no insulin and suddenly you go into ketoacidosis. So this is a very important area to work on, but it has to be done it's a complicated, challenging area. The problem is the cost of even the basic pump is around 1.5 lakhs. And it goes up to 5 to 6 lakhs. We don't have these pumps, these fancy ones available. So even the real-time ones are around 5 lakhs are the minimum cost. And then you have to put the tubings, which cost around 5,000 rupees every month. So these are the two things which really make them very expensive and prohibitive. So if we can have a technology which is more affordable, maybe in terms of pumps or maybe initially even in the form of the tubings, because I don't know why the tubings are costing so much. They're just plastic cannulas. As to why they are costing so much, if even those things can come down and the pumps something can be worked on, this is going to be a boon. Because at the moment in Australia, 90% of children are on pumps. In India, 1% would be on pump. And this is the way we are looking at. We want people to go into pumps. But the cost is a major factor. So if this can be cut down, and maybe if the government can then chip in and maybe do some other help or assistance in that regards, this will be the best way forward in terms of outcome. Because this will help their lives, and it's known that their quality of life improves with pump, glucose becomes less fluctuant and things become better with pumps. But I think this is going to be a big challenge. So I'm sure some of you will think of innovative designs on that. Yeah. Okay, yeah. Yeah, I think that will be quite good. Yeah, because even the Medtronic people say that, because I was talking to them as to you make things so expensive and how we can come down. So they said that maybe tubing is something that is very expensive because they come from US or whatever. So, yeah, so I think this could be one good area. And then pump obviously is a big challenge, but then this should be taken up by situations. So now we have talked about the problems of ambulatory care, invasive monitoring, injections, and finally the cure. So cure is a big issue and everybody talks about that. 6-year-old boy diagnosed with DKA had a very bad hospital stay, discharged after 7 days, but lost to follow up because parents wanted some other cure. Because we had told there is no treatment, you give insulin for life. They went and took some Ayurvedic, homeopathic, Unani, whatever medications and came back again with the same problem. Because they want cure and we are not offering one. So this becomes a big issue. So what can be done for cure? You can transplant the whole pancreas, but this is a major undertaking. You have to give immunosuppressant medications for life. So if somebody is having a renal transplant, then you give pancreas along with that, that's fine, but not on a routine basis. There are talks about islet cell transplant, in which you just extract the islets, beta cells, and then you inject that. It doesn't require that much problem, the immunosuppression is less, but again not very effective. More studies show that maybe in a couple of years your insulin requirement will come down a bit, but you won't be free of insulin. So the way people are working on, a lot of work is about stem cells. Yeah. Yeah, so this obviously you have to give a lot of strong immunosuppressant medication. So the pancreatic transplant is only done if you are doing concomitant renal transplant, for which you are giving a lot of medications. For the beta cells, they have a life which will go off in some time. You can inject, it's like an IV injection which you can give. The immunosuppressant is much milder. They go into the pancreas and then they start working like that. And now the interesting thing was the beta cell patch, in which you can actually put the patch there, but then again for a few days. So it's a challenging area, but more people are working on in terms of stem cells. And every day we see children who say that there is some stem cell therapy available in some place. So this is all fake, which is talking about, at least in India we see a lot of things, in China a lot of people go there. But there are work going on stem cells, but again I think this is one area which can really change. So if we can have easy access to stem cells and give it to the child, things will be the best solution. But I know it's a very challenging thing, how to de-differentiate your adult cell into a basic embryonic cell and then re-differentiate into a stem cell is challenging. And there was a lot of hope which came up with this publication about beta-tropin, which was a compound which was supposed to really increase beta cell mass in the lab. So people thought that now we can produce as much beta cells as possible and it will go forward. And this was actually driven by Douglas Melton, who happened to be a father of a child with type 1 diabetes for 20 years. So he had been working for 20 years on that, and he was hopeful, we were all hopeful. But unfortunately, it was not proven, and in fact this paper had to be retracted, the beta-tropin paper. So this was a sad development, and this reminds us as to what my professor used to say in Australia, that we have been saying since the 80s that the cure is going to come in the next 5 years. And still after 30 years, we are still, now it's 40 years, we still say the cure will come. So this is a big hope in terms of that, but how it goes, so this is going to be a big area to work on in terms of technological intervention. So there is a scope for technology in every parts of type 1 diabetes about empowerment. And I think we talked about the various applications which can help in terms of children, mobile applications, communication in terms of their sugar readings, in terms of non-invasive glucose monitoring, definitely, new tools, physiological delivery, cost-effective pumps, consumables, tubings will be of help. And then finally, if somebody can find the cure, we have a Nobel Prize which is there, which will be won if somebody finds the cure for type 1, because this is such a huge issue overall. So if we just, I think this is what we are going to end on, but what I'm trying to say is that I have come here as maybe a representative or an advocate of children with diabetes, because I see every day so many children and they have so many problems. And now I've tried to put my case to you, and you have to work on it and get solutions and improve on that. So that is the way. And we would be more than happy to interact. We have the whole team which is there in terms of pediatric endocrinology, Dr. Chetan, Dr. Riddhi and Dr. Neha. And we have been working a lot of in terms of clinical problems that they are having in their complications, in their bones, and their other things. And we know that they have a very difficult life to live with. But they are really very strong fighters and they do really well. We just need to support them. So if we can do even some part of it, I'm sure this is going to be quite fruitful exercise on that. And then I'll thank Dr. Amitabh again for inviting me and presenting me to this very nice platform.
Thank you. Questions? Yeah.
What is the problem with the patch?
Yeah, the patch, the problem is there are two types of patches which are there. One is the insulin patch, which basically is put in the skin and then it delivers the insulin. The problem is that how much insulin goes in, because it's not a mechanical thing. It's basically like a simple patch. The beta cell, again, the durability is a problem, because in most cases getting beta cells also is not easy. And how much time will it be there for that time, because it will vary from that. And then again, whether it will be, and how do you know that beta cell is going, that patch is going off? These were the issues which were there. So like suppose you put in so many beta cells, how do you know they are still functioning? Because then you have to decide how much insulin is to be given, because it is not insulin. So now that beta cell is producing insulin, it may behave in an unpredictable fashion. So maybe you need, just example, 1000 cells. Now you have got 800, 600, whatever. So how much extra to give? So it's a challenging situation. If you have something which say, okay, you have a renewable source of beta cell which is going there, then it will be definitely, then you can be off insulin. But otherwise I am worse off that how much insulin to give today and maybe 5 days later, that becomes the issue.
And how much would that cost the beta cell bank?
No, that's basically still in the research phase. None of this is commercially available.
Do you have any idea how much?
No, it's like a research, these are all just research flashes. So most of the developments we are talking about are actually at a research level. Pumps are there which are working a lot, and I think that is another issue, whether it's a deliberate ploy or something, because the advances in terms of the technologies to deliver insulin and pumps and monitoring are much faster compared to the actual curative strategies. I know it's going to be difficult, of course, to go for a curative strategy, but probably more funds are being put, because the companies will obviously put funds where they have a revenue on that. So this will be a one-off thing. If suppose everybody of type 1 is gone, then maybe insulin companies don't want that to happen. So I don't know, this is one of the hypotheses that we have, which may be true or not, but that is one point. So definitely we have so much advances in technology, but we don't have that much advances in cure part. It's basically based on government funding and other things, I think, even in US, that's the...
Particularly in the
Yes. Yes, sir.
Like, is there any work going on the prevention of type 1 diabetes from happening?
There is a huge trial which is going on in terms of prevention. They are focused
Mainly on relatives of children with type 1 diabetes, because they are the most likely to develop. Because general population, we say 1 in 300, we can't have mass prevention strategies. So there is a risk of around 4% in terms of siblings developing diabetes. So they do is screening using antibodies. If they are positive, then there have been trials on various things. They have tried immune trials like oral insulin, inhaled insulin, subcutaneous insulin, and the crux is that none of them has been found to be effective. So the issue out there is that we are talking about immune tolerance. Tolerance is not going to help a lot. The other way to look at it is you give immunosuppressants. But immunosuppressants you don't want to give to somebody who is only 4% chance of developing diabetes. So we are trying a very mild solution. It's just like a homeopathic way of treating, I think, which is not going to work. We know that. So there are lots of trials on inhaled insulin which is going on also, but none of them have been found to be effective.
type 1 diabetes is an autoimmune disease, right?
Yeah.
No effort is on to identify the antibody that recognizes and utilizing antibody type therapy.
So basically the problem is that it is mainly a cell-mediated immunity. The autoimmune, the antibody process is a secondary response. So when we see those antibodies like GAD antibody, these are because cells are now damaged, they are exposed, and then you have a secondary antibody. But main problem is the cell-mediated immunity. So there is work on the various monoclonal antibodies for CD molecules, CD32 and a lot of those molecules which act on the CMI part of it. There is work going on that, but you don't want those medicines for somebody who is absolutely healthy. So this has been tried mainly in children who are in the honeymoon phase. So in which they have some beta cell function there, but it is being damaged. So there they have been tried to prolong the honeymoon phase. And they have been found to prolong maybe from 6 months to 2 years. But they don't really improve. But then you have to give such a strong medicine for a simple thing. So that's the whole problem with us. Yeah. Yeah, so because basically insulin is a protein, it is all digested in the stomach. So there are talks about various forms in which can be prevented from that hydrochloric acid degradation. There is a phase 2 trial on oral insulin which was being done through Biocon, but actually the bioavailability was not good enough on that.
So you mean that the only target is to stop the degradation by HCl?
Plus the release, we are mainly bothered about it should be able to achieve a good blood insulin level.
So has anyone tried giving some sort of indestructible pills that can pass through the stomach region and reach?
But then how will they be absorbed from the intestine?
So the second phase has to be something that will be glucose responsive, like low blood glucose will automatically open up. So if it is a closed capsule, which can withstand
So
HCl,
you have
and
something
then
like a chip that is implanted inside, which has a depot of insulin or something like that. And then it's a smart chip which can sense also and release. Like it's like a.
So that's basically, yeah, so it's like a pump that we have. You're talking about a very miniature pump. Yeah.
Inserted inside.
Yes, yes. So pump is something like that. So it's a big thing. It's like from outside it is giving that. The ideal solution, the other issues which I have not talked about is that when we talk about actual sugar levels, we are talking about portal insulin delivery in the actual portal system. While whatever way we give insulin is all in the subcutaneous, which goes to the blood circulation and then goes to the liver. So this is another major area, so that's why we are never able to achieve a physiological replacement. And the sugar you are going to target actually measuring in the pancreas rather than the sugar in the blood. So it's a very complicated process. So till now we are just scratching the surface. We are even trying to see how the interstitial glucose, which may not correlate very well with the pancreatic glucose, and we are giving it in the skin, hoping it goes to the blood and goes to the circulation. But it's definitely much better than what we are doing. Will be something like a very small pump, basically what you're trying to do there. Yeah. The problem basically is, the problem is how do you get a glucose sensing. So beta cells are wonderful things basically. They have got a GLUT2 transporter which allows glucose to go in. They have a glucokinase enzyme which tells you how much glucose is there. Then they secrete insulin and they shut down. So we are talking about as a beta cell, if we can do something, artificial beta cell or something maybe. But that is a big challenge on that.
Take your own cells and make them.
That's the other way around. Yes, definitely. Yeah.
Does the estimated amount of insulin vary hugely, or it's more or less similar for children of that age?
There is a reasonable range which is there, but it will vary upon a lot of things as to the environment they are, how much they are eating, how much they are playing, how much they are sleeping, because glucose level will depend upon 100 things. So usually there will be a range 0.6 to 1 unit per kg per day, but then it will be different for every child, and every day that child will require different insulins. That's the problem basically.
So can you give an estimate of an address insulin for a normal case in grams?
So what we can give is that what is the requirement in terms of units. So you can convert it into grams or whatever is there. So there are international units per kg. We express insulin doses into IU per kg per day. So IU is based upon some biological assays earlier, but they are now equivalent to some of these micrograms or whatever. You can easily find that out. So the general requirement is between 0.6 to 1 unit per kg per day in most cases. But as I said, if this child has not slept well, next day he may need more. If he is playing more, he may need less. These things will happen. But this is a rough idea which is there.
Can saliva be used for the non-invasive?
That is a very interesting thing to look at, because glucose actually is a small molecule. So theoretically glucose we do measure salivary cortisol and other things as a marker rather than looking at the blood. So, but I'm not sure it has been looked into.
So if, say, a group of students, after doing some brainstorming, wants to sit down with you to understand physiology a little bit more,
definitely.
Will you be available?
Definitely. It will be a pleasure. So I think we can do some homework on that, and you can also look at what are the salivary, what are the other non-invasive methods which have been used till now.
So
Saliva,
can,
but
as a group or individually, you can brainstorm, think, and then you can run it by Dr. Bsbe.
Because I would say that easy pickings are obviously the apps and all, they are very easy. But talking to this audience, if you make an app, I don't think it's going to really make a justice on that. So what we are looking at, maybe saliva or maybe some technique to look at glucose, because that could be a reasonably tangible goal which can be achieved. I know stem cells and all are very long drawn thing. We can start work or think about it. Pumps may be good if you have a mechanical department which is working in terms of delivery things, and those things will be of help. So this is just to idea to open up, and then we can go forward whatever is there.
So we are talking with a company,
Yeah.
which is again an alumnus company. They are in the area of piezo pumps.
Okay.
They are very keen on working with IIT Kanpur through CSR funding. So if good ideas come up, we can certainly interface and take it forward.
I think because the way we can make the maximum impact, I would say, and I think Dr. Chandra will agree, is that if insulin pumps are available for everybody at a reasonable cost, that is the best way forward. All things said and done about negatives I've talked about, that we are not talking about the physiological delivery and all those things. If we are able to give pumps to children, that will really change their lives hugely. Second would be non-invasive monitoring, because that's a big hassle. If there is something, if I have a watch or something in which my sugars come up, like my heart rate comes up, this is the best thing, because we know night time what is happening. Because this is what we say, if you check sugars 4 times a day, that is 4 seconds a day. You don't know what is happening for 23 hours, 59 minutes and 56 seconds. So if something like that can come up, maybe through sweat or saliva or whatever, iontophoresis, whatever, because glucose watch was talked about 20 years ago, but it has not come into the market still. So there are hindrances which are there. That was supposed to be a watch which you wear, and then it will extract the sweat, and then you measure the sweat glucose, but somehow it didn't correlate or whatever, because it never came to the market. That's a very huge innovation which is there to be done in terms of, because that will affect everybody, type 1, type 2, so many, that will be then crores of individuals will come into that.
What triggers the cell-mediated immune response?
There is a genetic predisposition, so these individuals have some specific genotypes which really predispose them, and then usually it's an environmental event, maybe an infection or a fever, some talk about diet. So it's we don't have a one-to-one relationship, but we know you have to be both things, you have to be genetically predisposed, and something happens, and then you have the trigger of CMI which happens.
And how somebody can identify the children is going to get type 1 diabetes?
So the prediction which has been done has been based upon 2-3 things. One is the HLA phenotype. So these individuals have a specific HLA phenotype, HLA-DR, which is associated with type 1 diabetes. Then if you combine that with the antibodies. So antibodies are secondary phenomena, but they happen early in the course of disease.
So this is a clinical parameter.
Yeah.
By seeing the children.
By seeing the children, nobody can do. Nobody, no ways.
Maybe there are health issues.
No, that will be too late. That health issues will happen when they have developed diabetes. We are talking about picking up diabetes when it has not happened, or we are trying to do when we can do something on that. So that will be antibodies, that could be HLAs or other things. Clinically, there is no way. You will pick up only when they have increased urine output and the child is already very sick and already their beta cells are 95% are damaged by that time.
So if you come to that if child is through HLA,
Yeah.
that child is predisposed to diabetic condition,
Yeah.
can we do something about it?
That's the problem which Dr. Chandra talked about. There's huge trials which are going about prevention. So from there, whether you can delay the cell-mediated immunity, whether you prolong the phase or you cure, there have been at least hundreds of trials and none of them have been shown to be effective. They've used nicotinamide, they've used GAD, which is the antibody which is being formed, insulins, oral insulin, inhaled insulin. None of them have been found to be effective. Probably we are using a very mild tool to correct that problem because we're talking about huge population. You can't use a strong immunity as we were discussing in this situation because that may cause more harm than benefit. So the problem with type 1 is that of course we have such a good therapy, insulin is there. So nobody is going to experiment with that. Unless something is safe and effective, we are not going to use it because that will risk the life of the children. So in situations like let's say childhood cancers, when you don't have any opportunities, you can be more aggressive in terms of newer developments. But here it has to be against the gold standard insulin therapy which is available. Yeah. So urine sugars have been used a lot for a long time earlier when blood sugars were not available. The problem with urine sugar is that there is a threshold phenomena. So it's not like that you will have a linear relation. So after 200 glucose, your urine sugar will be positive, and then again it's not a linear relationship. So the only role urine sugar will have is if the sugars are very high, your urine sugar will be positive. It will never tell you that the sugars are low in that perspective.
So I don't know whether it is myth or real. The story is that Dr. Bidhan Chandra Rai, Dr. Bsbe, apparently could detect a diabetic patient just by entering the room and smelling it. So, but I know that in ketosis you will.
No, it can happen because there are dogs which are trained in US to identify hyperglycemia.
So, Mr.
Yeah.
Can we think about if we know the metabolites well?
Yeah.
Some of which are volatile.
Yeah.
And if the sensitivity threshold is increased,
Yeah.
That form a basis of all.
Yeah. The only thing that then they need to have a very good correlation with the actual blood sugars.
So
Yeah.
for that, the physiology has to be understood really well.
Yeah. But I think that's a very interesting idea because there are dogs which tell you that you are developing hypoglycemia, you are developing hyperglycemia and ketosis. So they have been trained because of the smell sensation. So I think this is a good way to look forward. But then what will be the way you will analyze the data? Like how will you come out with that correlate?
See, like if we have very good understanding of exactly what metabolite to look at and
Yeah.
what is the metabolic pathway and the
Yeah.
relationship with glucose level,
Yeah.
algorithms can be developed.
Okay.
Is
Yeah.
my
Okay. And you can assess it using what? Like what will be the instrument?
You know, there are two giant chemists sitting here. They can always come up with sensors that can
Okay.
one chemical or the other.
So that will be a very good.
Yeah, you can even have done that.
But I think that's a very good idea if we can think of that way because theoretically it's definitely much more easier to measure that metabolite per se rather than the glucose.
Yeah.
So that will be the alternate way of going to.
And some of these are known to be volatile.
Okay, yeah.
Because that's how the drugs.
Yeah, yeah, definitely, yeah.
If there are no other questions, I think Dr. Bsbe really deserves a very good. I will request Professor Mukherjee to do the honor this time. You are the senior most in the audience. So, you know, Dr. Bsbe came all the way and gave such a fantastic talk. So
Thank you, sir. Thank you. It's a pleasure.
But I think we have taken some pointers, and I'm
Yeah.
hoping that students will come up with good hackathon solutions.
And our whole team is there who are trying to work in the same direction. So
you
we'll
will
be.
have many people to work for. You will have the doctor's team to work for. You will have the team to work for. You have the Bsbe department and the chemistry department. And you have many friends. Okay, just scratch your head and come up with ideas. Okay, we will try to solve. Thank you. Janaki, will you kindly take care of
So, for everyone, we'll be sending out an email with a QR code. Just scan that code and you would be directed to the Google form that we have created. All the problems that are highlighted by Sir are
Thank you. It was very
existing
interactive,
there.
everybody.
These
So
are problems.
it's good to talk to different
Provide a
audience
solution by this
because
weekend
we
and
talk
you
mainly to
submit
medical
your
audience
response
or
by
the-
And
Monday.
the audience had lots of questions. And
Yeah.
they understood
Monday
what you were
midnight.
saying.
definitely. So
Right. So
if
it
we
was
can do
effective, I
something.
think.
Yeah.
2000
So if you're able to get something
Out of
out of
it.
it. Thank you. Great to have